Hello and welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases, and my topic for today is cocaine syndrome. Now, to help us understand this in a little bit more detail, in a little bit more depth, we have with us today Dr. Pradeep Kumar Shetty, who is an accomplished neurophysician specializing in medical neurology, currently practicing in Fortis Hospital. Now, he is recognized for his clinical expertise, research contributions, and also commitment to patient care. He has a medical experience of 9 years, and his areas of expertise include neurology and medicine for both outpatient and inpatient cases, expertise in handling stroke or migraine and headaches, movement disorders, epilepsy, demyelinating diseases, neuromuscular disorders, cognitive disorders, Botox administration. He also has an expertise in NCS, EMG, EEG, lumbar puncture, expertise in scalp and video EEG, intrathecal drug administration, nerve, skin and muscle biopsy, and also his proficiency in neurology and medicine intensive care. So welcome to Medical Dialogue, sir. It's really a privilege to be having you on board here with us today.
Thank you so much.
Great. So now, sir, we'll go ahead with the topic of cocaine syndrome, and you can just give us your valuable insights on the same.
Hello everyone, myself Dr. Pradeep. Today let's have a small brief talk on one of the most rarest syndrome in the world, cocaine syndrome. So what is cocaine syndrome? It's a rare genetic disorder which results from a DNA repair defect. As we know, our cells has a DNA, and each DNA has many millions of genes which will control our body function by expressing hundreds of proteins. Even a minute mutation or a small defect in a gene will result in a variation of symptoms as well as syndromes which can manifest in various kind of diseases. As we know, it's a very rare genetic disorder, and the main reason for this is a DNA defect. These patients usually have a heightened sensitivity of cells in affected individuals to the lethal effects of UV light. As we know, our sunlight mainly contains UVA and UVB. However, the normal cells usually are resistant to the damage caused by the UV light. In these patients, they have very high sensitivity to the UV lights, resulting in significant damage to the cells and the DNA, causing mutations. These patients have a unique facial characteristics like sunken eyes, big nose, and the prominent ears, and also experience progressive dementia in the sense, and the progressive reduction in intellectual abilities and memory disturbances, which we will deal in detail in the subsequent slides. Coming to the incidence of this disease, it's very rare, wherein the incidence is overall in the world is 1 in 25 lakhs or 1 in 2.5 million live births. Coming to the etiology, so what causes cocaine syndrome? It's an autosomal recessive. So medical term, we say it as autosomal recessive. Autosomal recessive in the sense the affected individual will have two abnormal genes. So one from the father and one from the mother, or it can be the two mutations can occur in vitro. So both the two defective genes should be there to cause this disease, and this is due to the mutation in ERCC genes, which we localize in our DNA. The gene which is affected in this cocaine syndrome is called as ERCC genes, among which there are two proteins. These genes will code for CSA and CSB proteins. So as I told you, in our system, in each cell, we have DNA which will have thousands of genes, and these genes will replicate into many proteins which are the fundamental of our cells. So these ERCC genes will encode for CSA and CSB proteins. These proteins will mainly protect us from increased sensitivity to the UV light. So due to a mutation in these genes, there is a compromised DNA repair mechanism, as a result of which our body, the patients with cocaine syndrome, are very highly sensitive to the UV light, resulting in subsequent damage to the cells. So there are various types of cocaine syndrome based on the age of presentation and depending upon the degree of mutation in the genes. So usually we have three types of cocaine syndrome type 1, type 2, type 3. So type 1 is the most common form that usually manifests during the childhood. Cocaine syndrome type 2 usually manifests at birth and presents with more severe symptoms compared to the other types of syndrome, and usually this is a very severe form of cocaine syndrome. Cocaine syndrome type 3, it appears later in the childhood but with less severe symptoms than any other types of syndrome. So coming to the clinical features, how the cocaine syndrome manifests, how can it be easily detected, what are the symptoms which we can notice in the newborn. Mainly the growth related disorders and the physical features. These affected children usually have a progressive growth restriction, usually which we see between ages 1 to 2. As we know, during the development of child, we have a developmental milestones starting from even the 2 months, wherein we can expect neck holding, and subsequently the child starts crawling, sitting, standing and walking. And in these kind of children, you can see a growth restriction wherein delayed neck control, delayed sitting, delayed walking, and this kind of usually symptoms we can notice between the age group of 1 and 2. And these have failure to thrive and microcephaly. Failure to thrive in the sense they have very less compared to the normal. When they compare to the normal children, the development with respect to their physical characteristics, to their growth, bone growth, will be very less compared to the normal child. What is microcephaly? Microcephaly is a small head. As we know, when the child is born, the head size gradually over a period of few months, it will increase by every 3 monthly, we say by 1 centimeter. In this kind of children, usually the head growth or the brain growth is defective, so that these children usually have a microcephaly. As these children age, they lose subcutaneous fat, resulting in a prematurely aged face. This is one characteristic feature of cocaine syndrome. As we know that the newly born children usually have a lot of subcutaneous fat tissues in the cheeks. This cocaine syndrome child usually subsequently they lose this subcutaneous fat, and the skin looks as if it has been prematurely aged, like the skin of an elderly 60 plus. You can see a lot of wrinkles, and these children usually by the age of 2 years, they usually have a lot of wrinkles around their cheeks, resulting in that prematurely aged faces. The other dysmorphic features in the face includes they have prominent ears, sunken eyeballs, a big nose, and a cachetic body with thin and slender limbs. They will be very cachetic, very thin and slender limbs. Coming to the neurological disorders and the intellectual development features of cocaine syndrome, as we know, since this is a genetically mediated disease, these genes are also involved in the CNS maturation, which we say is myelination. Since this neuronal systems are involved, these children will have progressive sensory neural hearing loss. Progressively, the child might not be able to have proper communication due to the defective hearing, and they may ultimately end up to results in complete deafness by the age of 3 or 4. They have intellectual disabilities in the form of difficulty to interact with the parents, with the children. They usually have less interaction with their interaction, and hardly they involve in many kind of activities like playing or they have difficulty in walking and unsteady gait, wherein they try to walk with a sort of imbalance, which we say it as ataxic gait, poor balance, and over a period of time they will have progressive stiffening. Their both upper limbs and the lower limbs will become so stiff that their walking will have a very typical nature of in the form of, like, so we say it as spastic gait, wherein they tend to drag their legs while walking. And some patients do develop epilepsy, wherein they have a tendency to develop seizures, multiple types of seizures, and for which it has to be medical attention has to be taken and treated. They have a wide spectrum of epilepsy in the form of either absence seizures or a generalized tonic-clonic seizures. Coming to what is polyneuropathies, as I told, these genes, and these genes are expressed in each and every cells at the same time, even in the central nervous system and in the peripheral nervous system. And due to the involvement of peripheral nervous system, these children usually develop polyneuropathies, wherein they will have distal extremity weakness, and they can have food drop, wherein the child usually will have weakness of the distal muscles of the foot, and they have significant difficulty in walking. Coming to the skin findings, as I told, these children are very much prone to the UV light. These have thin and sensitive skin, which makes them susceptible to severe sunburns. As we know, normally when we are exposed to the sunlight, hardly we develop sunburns unless until you are very sensitive to the sunlight. These children usually are very, very sensitive to the UV light, as a result of which they can have recurrent sunburns. Even minimal exposure to UV rays can lead to sunburns with subsequent scarring. As we know, when there is skin sunburns, the resulted skin will go for healing and then cicatrical and scarring, wherein it becomes very thick. The skin also exhibit hyperpigmentation, telangiectasia, and atrophy. Hyperpigmentation, as I know, during the healing process, there may be more and more pigmentation to the affected part, followed by abnormal vessels, which we say it as telangiectasia, wherein in the skin you can see some sort of abnormal blood vessels getting developed. Subcutaneous lipoatrophy contributes to the development of sunken eyes and the prematurely aged. Progeric appearance, as I told you in the previous slides, the subcutaneous tissue over the cheeks will be lost in these children, and as a result of which they usually develop a sunken eyes, and that typical faces which we say as if the child is to be the face appears like a 60-year-old face. We medically term it as a progeric appearance. The common findings, other findings include cyanotic acral edema of the extremities. Cyanotic acral edema in the form of like bluish discoloration of the distal extremities of the hands and the foot. Nail dystrophies, they may have abnormal development of the nails, and hair anomalies. This is the photographic feature of a child with Cockayne syndrome. As we can see in the top slide, this is the child at 6 months. Typically a normal skin faces, normal face without any gross dysmorphic features. Like you can see the skin, the chubby cheeks due to the normal subcutaneous fat. As you can see, this is the second child. Okay, patient 2 at the age of 6 months, the same. It looks a normal, fairly normal child. When you see the Down's picture, the same child at the age of 4 years, as is, you can see there is lot of loss of subcutaneous fat tissue, and these eyeballs are very sunken. They have a very discolored hairs, and this you can see the same child at the age of 4 years, wherein there is loss of subcutaneous fat with sunken eyeballs. And this is called a typical progeric faces, as if the face looks like a very elderly face. So what are the other abnormalities coming in Cockayne syndrome? We have dental abnormalities, wherein the child have small irregular teeth which are abnormally spaced. The permanent tooths may not develop in these children's. When they do so, if in case they develop permanent teeth, they usually remain very small or poorly implanted. Easily it can be displaced or removed. The musculoskeletal symptoms includes contractures in the hip, knee, and ankle. Contractures are nothing but the permanent deformity, wherein permanent deformity due to the long-lasting muscular disease or the nerve disorders, resulting in a fixed position of the joints in the hips, knee, and ankle. The other musculoskeletal features are microcephaly. As I told, the brain size or the head size is very less for their age. They may be having a short stature, wherein their bone growth is hampered, so their height is not up to the age. The elongated limbs with joint contractures, the oversized hands and feet, and kyphosis. Kyphosis is a spine deformity, wherein the normal curvature of spine is not maintained, resulting in some kyphotic deformities, wherein it is bent to one side. And possible osteoporosis. Osteoporosis, as we know, there is a progressive weakening of the bones, resulting in repeated fractures even with trivial trauma. Coming to other features are ocular. Coming to the eye findings, usually these children will have a progressive diminution of vision. That vision problem can be because of cataract, wherein the lens gets opacified, and this results in progressive diminution of the vision. They may have issues with the retina, wherein which we say retinal degeneration. We have a retina which is the most important structure for our vision. Since these children usually have affection to the retina, so subsequently the retina undergoes degeneration and the child will have a severe vision impairment. And optic nerve is the main nerve which is present in our eyes, and it's responsible for our vision. This optic nerve subsequently becomes very thin and then resulting in optic atrophy to have a significant vision impairment. Anophthalmia usually arises due to loss of typical fat pad behind the eyeball. Anophthalmia is due to wherein, as I told, it's like a sunken eye. As we know, in the eye socket we have a lot of subcutaneous fat. When there is loss of subcutaneous fat, the eyeball looks sunken, and typically it looks like the one eye is just pushed inside the orbit. The others are cataract. As I told, there is opacification of the lens, optic atrophy due to thinning of the optic nerves, and corneal opacity. And these children usually are very prone to develop hepatotoxicity or liver failure to a lot of medications. As we know, the medications which we commonly use for fever or sort of infection, antibiotics, majority of the medications which we use are usually metabolized. It's usually metabolized by the liver and then excreted through the kidney. This Cockayne syndrome children usually are prone to develop hepatotoxicity even to a very small dose of medication. So we have to be very careful while prescribing medications for any sort of fever or infections, considering their liver. Considering their liver hasn't, as I told, they are very prone to develop hepatotoxicity, and itself can lead to their death. Coming to the renal disease, usually these children are very prone to develop hypertension in the young age group. As we can see now, due to a change in the trend and the dietary changes, we can see many young children coming with hypertension and diabetes. However, this Cockayne syndrome children usually will develop hypertension even in the first decade of life due to the involvement of kidney, and the uric acid level can be very high in this, and this can result in multiple joint issues. So, coming to the evaluation, how to evaluate this case of Cockayne syndrome? As we know, it's more of a genetic disorder which has to be identified as early as possible and can be used rather there is no treatment cure for genetic disorders all over the world. We can just minimize the complications by diagnosing as early as possible and counseling the parents. So the evaluation includes genetic, developmental, ophthalmological with electroretinography. As I told, ophthalmological mainly to look for cataract, to look for any retinal disease, and to look for retinal disease. And subsequently, if these are all the correctable issues, when there is any cataract, we can go ahead for cataract surgeries and the vision can be improved. Neurological evaluation, as I told, these children are very prone to develop seizures. So we do to look for seizures, we do EEG, which we say electroencephalography, wherein multiple electrodes are placed on the head to look for abnormal electrical discharges in the brain. And nerve conduction studies are to study for the peripheral nervous system involvement. As I told, the children are very prone to develop polyneuropathies. The nerve conduction study helps us to detect in an early stage. Gastrointestinal workup. As a gastroenterologist, the child may be required endoscopy to look for any other issues related to the gastrointestinal system. Audiological evaluation, as I told, this Cockayne syndrome children are usually develop progressive sensory neural hearing loss. When in the developing child, let me say at the age of 1 and 2 years, if their hearing issues are very significant, they may have a significant intellectual disabilities, they may be very poor in communication. So this, by audiological evaluation, the hearing assessment has to be done as early as possible to detect in an early phase. Other workup includes dermatological, as I told, plenty of skin issues with these children. dental evaluation and endocrinological, as I told, there are a lot of hormonal issues. Since the brain is affected, the growth hormone, it will be impaired in this kind of children, and we may have to look for other hormone assay and to provide supplements depending upon the level of growth hormone and other hormonal assays. The main stay of evaluation is genetic. As we are in a genetic era, it's always confirmation by the genetic testing. We do chromosome analysis, and there are plenty of genetic analysis which we can do in the form of chromosomal microarray, chromosomal break studies, mutational analysis. We can directly go ahead with the study of ERCC8 and ERCC6 genes. As I told you in the previous slides, these two are the genes which are mainly implicated in the pathogenesis of Cockayne syndrome. We can directly, if we have a suspicion of Cockayne syndrome, we can directly go ahead with testing for these two specific genes like ERCC6 and 8. And let me say, if parents have a firstborn child is suffering from Cockayne syndrome, and the child is already born and now we have diagnosed as a Cockayne syndrome, the parents usually have a dilemma. If they are planning for a second child, the first question comes to their mind is, what is the possible chances that the second child can suffer from the same disease? Yes, they will have chances of developing. If the first child is suffering from Cockayne syndrome, as I told, that's like a possibility of the second child being born with Cockayne is almost 25%. So it's very, very important for the parents to be counseled properly, and we can diagnose this antenatally by cell culturing from the amniotic fluid. As I told, before 20 weeks of the pregnancy, we can extract the amniotic fluid or the chorionic villus sampling from the umbilical cord. We take the samples and we can do genetic testing to look for these mutations, or even the skin biopsy from the affected child can be used to confirm the diagnosis. So coming to the management, as I told, there is no cure for genetic syndromes. However, we can improve their life by just helping to prevent further complications like sun protection from the skin and eyes. As I know, these children are very prone to be affected with the UV light, and they have more prone to develop sunburns. We can prevent the children from being exposed to sunlight or use of sunscreens with good UV, good protection against the UVB lights. Physical and occupational therapy, as I told, these children will have significant physical impairment, progressive intellectual disabilities. We need to provide them more and more of occupational therapies so that they can be able to handle some of the work by their own. Nutritional support, as I told, these patients are very prone to develop a lot of deficiency with macro and micronutrients. So we need to give exogenous nutritional support, dental and eye care, and hearing assessment. As I told, as early as possible, we can just prevent the other complications like intellectual disabilities, communication difficulties, when we detect the hearing issues as early as possible. Blood pressure monitoring and routine monitoring of kidney and liver functions and sugar levels. As I told, these children are very prone. They can develop early hypertension and diabetes. So routine monitoring every 6 monthly or yearly, testing the liver function test, kidney functions may help to prevent the complications. So coming to the prognosis, as we told, this is a genetic syndrome. There is no cure, but few children can be expected to go beyond the first decade of life. Cockayne syndrome type 1 usually maintain a good communication skills, although the death commonly occurs during the adolescence, 15 to 20s. Survival into adulthood is still possible if we can detect the possible complications, which can prevent for complications by detecting those issues as early as possible, and we can avoid using some medications which can cause hepatotoxicity. So this is how we can push their life till the second decade of life. To encourage socialization and age appropriate schooling is also recommended. Type 2, as I told, it's one of the severest form of Cockayne syndrome. They have very limited possibilities for interaction with the surroundings due to hearing and intellectual impairment. Usually this Cockayne syndrome type 2, they usually dies within the first decade of life. So type 3 exhibit a relatively almost normal early development, and they can attend formal schooling, however with minimal or low IQ compared to the other children.
Thank you so much, Dr. Pradeep, for joining us today at Medical Dialogues and giving us all this information about Cockayne syndrome and how it is a rare genetic disorder and how one can actually come to an early diagnosis if they understand the clinical features at the earliest. So thank you so much for joining us again and giving us all your valuable insights.
Thank you, ma'am. Thank you.